afternoon, everybody, and welcome to today's webinar on effective tobacco dependence treatment, medications for cessation. My name is Karen Labello. I'm Director of Education for the New York Chapter ACP. Our speakers today are Dr. Susan Urban. She's Clinical Associate Professor of Medicine in the Division of General Internal Medicine at NYU Medical School, and Dr. Michael Steinberg. He's Professor in Chief in the Division of General Internal Medicine at Rutgers Robert Wood Johnson Medical School. Before we begin, I'd like to review a couple guidelines. All participants will be on mute, and if you have a question, please type it in the dialog box on the right, and one of our panelists will answer your questions at the end as they come in. If we run over the allotted time, we will send the answers to your questions through email. Following the webinar, you'll receive an email from me with a handout of the presentation, and we will have the recorded version of today's webinar posted shortly on the chapter website under the resource menu of recorded webinars. This webinar is accredited for 1 CME credit and 1 MOC point. In order to receive your CME certificate of participation, we would ask that you complete a quick online survey, which will be sent to all of you in the email I send out after the webinar. I would now like to introduce Dr. Susan Urban and Dr. Michael Steinberg to today's webinar.
Thank you. Thank you very much. And I'd like to thank New York ACP for hosting this webinar on this great topic, medications for smoking cessation. So no disclosures, and you can go to this page to claim your credits. So today we're going to be talking about 7 medications for smoking cessation which are available in the United States. Very effective, evidence-based medications. 5 nicotine replacement therapies, including the long-acting patch and 4 short-acting forms. As well, bupropion, a pill, and varenicline, another pill, which was approved most recently in 2006. Unfortunately, fewer than 1/3 of smokers trying to quit use medications or counseling. And one survey in particular, noted that more than 2/3 of smokers wanted to quit. More than 1/2 made a quit attempt in the past year. But only 31% of smokers trying to quit use these evidence-based medications and/or counseling. So this is important for us as clinicians to step in and to advise and prescribe medications for our smokers who want to quit. On this slide, I've listed learning objectives. We'll be talking about evaluating smokers and discussing medications that we recommend for them. We'll talk briefly about mechanism of action. We'll compare 3 classes of medications that we discussed. And finally, towards the end, we'll talk about how can we increase the effectiveness of these medications. And throughout, we'll be applying these information to 3 clinical scenarios. So here's our outline. Background, I will discuss. Dr. Steinberg will talk about choosing and prescribing medication, 3 case examples. I'll then talk about how can we increase quit rates further and give a brief summary. So in 1964, first Surgeon General's report on smoking and health came out. The Surgeon General himself, Luther Terry, smoked cigarettes. Prevalence at that time was 42%, pretty high. By 2018, prevalence had decreased to about less than 14% in US adults. However, this is 34 million people, and smoking is still the most common cause of preventable death in this country. There are large disparities in prevalence and subsequent morbidity and mortality, which we also need to consider. These are some of the groups that have higher prevalence listed on this slide from MMR 2018. Just want to point out at the bottom right, people with serious psychological distress symptoms have an increased prevalence of about 35.8%. However, when you look at the combination of schizophrenics, bipolar, major depression patients, prevalence there is over 50%, around 53%. And when you look at the group of schizophrenics alone, prevalence can be as high as 79%. In addition, there is very high prevalence in alcohol and other substance abuse disorders. So, why do people smoke and why do they have so much difficulty quitting? We know it's the nicotine. We know nicotine makes us feel better. It's pleasurable. It's habit. People smoke in response to certain triggers. Genetics plays a role. And finally, dependence is critical. About 3/4 of smokers become dependent on nicotine. These nicotine-dependent smokers, when they cut down or quit, develop withdrawal symptoms. These withdrawal symptoms are very uncomfortable, and as a result, smokers start smoking again. This is where medications come in. They help nicotine-dependent smokers quit. So how does this dependence develop? Nicotine binds to receptors in the midbrain very rapidly, within 10 to 20 seconds after a puff, causing release of dopamine and other neurotransmitters. And this leads to nicotine dependence. Dopamine, as you know, is responsible for the development of dependence in general. So on this slide, I've listed the criteria for dependence on the left side, starting with compulsion to use and ending with withdrawal symptoms on the left side of the slide. Again, it's the withdrawal symptoms that make smokers continue smoking when they try to quit. Makes it very difficult for them to quit. On the right side of the slide are listed the withdrawal symptoms, including depressed mood, insomnia, anxiety, increased appetite. These withdrawal symptoms can start as soon as 4 hours after the last cigarette, peak in around 3 to 4 days, subside over 3 to 4 weeks. However, hunger can last much longer, and cravings can last months to years. So as we said, medications work to help nicotine-dependent smokers quit. How? They act on the dopamine pathway and decrease withdrawal symptoms. So for example, nicotine replacement therapy supplies nicotine, which binds to and stimulates the nicotinic receptor more slowly and less strongly than from a cigarette, but increases levels of dopamine nevertheless. Bupropion inhibits the reuptake of dopamine and norepinephrine, increasing levels of dopamine. Varenicline is a partial agonist at the alpha-4 beta-2 nicotinic receptor subtype and increases dopamine levels. And both bupropion and varenicline, by the way, act as antagonists as well to the nicotinic receptor. So we know there is a very strong evidence base for the effectiveness of medication and counseling in smoking cessation. This guideline 2008 update concentrated on adult smokers who want to quit, and we're still using that paradigm today. They refer to 5 A's, brief interventions that clinicians, health systems can use. Ask if someone uses tobacco, advise to quit, assess whether they're ready to quit in the next 2 to 4 weeks, assist them with quitting if they are ready to quit, assist with medications and counseling, and then arranging follow-up is also essential. They point out that medications and behavioral counseling are both important in helping smokers quit, and that both together are more effective than either one alone. So what are the quit rates at 6 months for medication and counseling? You can see on the left side of this slide, single form of NRT and bupropion both have similar quit rates at 6 months, 17.6% for single NRT and 19.1% for bupropion. Now, of note, on the right side of the slide, varenicline by itself has a quit rate at 6 months of 27.6%. That's impressive. And combination NRT has similar quit rates at 6 months as varenicline. So let's review briefly these 3 classes of medications. There are 5 types of NRT, as we mentioned at the beginning: the long-acting patch and short-acting forms of NRT. Important to note that the patch is passive. That means that the user cannot adjust the dose according to symptoms. The patch supplies continuous nicotine through the skin to the system. Short-acting forms are active. That means the user can use them as needed for their withdrawal symptoms. We'll come back to that more later in the middle section. The 5 types of single NRT are similarly effective. It's important to note the combination NRT patch plus short-acting form is more effective than a single NRT. According to one Cochrane review, risk ratio of abstinence 1.25. Very safe. Nicotine replacement therapy is very safe. One precaution is MI in the prior 2 weeks, severe angina, life-threatening arrhythmias. Bupropion was initially used for depression. It's an antidepressant. Was approved in 1997 for smoking cessation as Zyban. One thing to note is that the seizure risk with bupropion is 1 in 1,000. So bupropion is contraindicated in people with seizure disorders or people who have a strong chance of developing seizures. For example, people with a history of recurrent eating disorders, people who abruptly stop benzodiazepines, barbiturates, heavy alcohol use. And finally, bupropion is contraindicated in people who have used monoamine oxidase inhibitors within the prior 2 weeks or medications with those qualities, like linezolid, for example. Because when bupropion and monoamine oxidase inhibitors are used too close together, there can be very high blood pressure surges. Let's go to varenicline, the most effective single agent. It has many precautions, some of which are listed on this slide. In 2015, added seizures and interaction with alcohol. Also, please notice that varenicline can decrease the ability to drive or operate machinery. It's very important to counsel patients about that. Of note, varenicline is safe for use in smokers with psychiatric disease. We will come back to that shortly. We're talking mostly about medications today, but behavioral counseling is very important, as we mentioned earlier. It's important to counsel the smoker who is planning to quit, specifically about withdrawal symptoms, what to expect, how to deal with them, how medication can help, about triggers, what their triggers might be, and what kinds of things they can do to help them with these triggers. It's important to counsel about medications, as we said, how they work, and what the patient wants to use and what we recommend, as well as possible resources for behavioral counseling and the importance of it. Arranging follow-up, remember, was the 5th A. So it is important right after the quitting date to discuss with the smoker who has quit, whether they have quit, in fact, whether they're currently smoking or not, whether they lapsed, whether they're taking the medication, whether they can deal with the side effects of medication, how they're dealing with withdrawal symptoms, triggers, what their concerns are. So now I'm going to turn this over to Dr. Steinberg, who is going to talk about choosing and prescribing medication, 3 cases. So Dr. Steinberg is going to take over at this juncture.
Okay, thank you very much, Dr. Urban. I really appreciate it. I want to add my thanks to New York ACP for allowing us to present this. So now you have some background in terms of tobacco treatment principles. We're going to apply those principles and use of these medications to 3 clinical scenarios here. You see Charles, Rachel, and Richard. So Charles is our first patient. He's 35 years old. He smokes a pack a day. His first cigarette in the morning is 30 minutes after waking. He had quit once before a few years ago using the patch, but relapsed. He would like to use it again. He has a history of alcohol dependence, and his last drink was 4 weeks ago. Otherwise, he has no other medical or psychiatric history. So just want to mention one of our measures of nicotine dependence, tobacco dependence, is something called the heaviness of smoking index. It's basically a scale that uses how many cigarettes you smoke per day and when you have your first cigarette in the morning. And you can score this and gives you a scale in terms of the level of dependence for the person. So in terms of medications, usually what we'll do is have a conversation with Charles, our patient, and kind of talk about nicotine dependence as well as psychiatric and substance abuse history. So in his case, alcohol use disorder. You take into account patient preference, including the patch and what's worked before, and then medication cost and availability. So in that discussion, you and Charles decide that NRT is preferred over varenicline or bupropion. You want to consider contraindications and cautions, as Susan had discussed briefly before. Patient preference, which Charles preferring NRT, considering the Charles's history in terms of his alcohol history. So as Susan had mentioned, varenicline can interact with alcohol, and bupropion can lead to seizures in people who may suddenly stop using heavy alcohol use. So based on all this, your decision with Charles is to use combination NRT patch plus short acting. So I just want to go through each of the nicotine replacement medications. The patch is over the counter and comes in 3 doses, 21, 14, and 7 milligram. You want to use the higher dose in people who smoke 10 or more cigarettes per day. And you can see that the medication is tapered over about a 12-week period. You want to start this medication on the quit date, although it can be started prior to that. We're going to talk about that later. The duration is to taper over a few months, and again, the duration can also be longer. And in terms of side effects, the most common one is some skin irritation. That usually occurs from the adhesive. People are not having a reaction to nicotine. They've been getting nicotine from their cigarettes for many years. It's the adhesive that they use can cause some skin irritation. Nicotine gum, also over the counter, comes in 2 and 4 milligram doses. You, again, want to start nicotine replacement on the quit date. You want to tell people to chew and park the nicotine replacement, the nicotine gum. The nicotine is released by the gum and is absorbed orally in the lining of the mouth. You don't want to eat or drink for 15 minutes before or after using the gum. Most common side effects are local, some nausea, and some jaw soreness from chewing. I'm just going to ask, maybe somebody could mute their phone on this line because I'm getting an echo. Nicotine lozenge, also over the counter, comes in 2 and 4 milligram doses. You also want to start the nicotine lozenge on the quit date. The lozenge works similar to the gum, except you don't need to chew it. You let it dissolve in your mouth. Each lozenge lasts about 20 or 30 minutes. There are mini lozenges, which dissolve more quickly. And again, side effects are similar, nausea and some maybe heartburn. There are 2 nicotine replacement medications that are prescription medications. The first is the nicotine oral inhaler. It's not really an inhaler, so the name is a bit deceiving. We like to call it a puffer. The nicotine inhaler works also through oral absorption of nicotine, so pharmacologically it works very similar to the gum or the lozenge. And you basically take this inhaler, you puff on it, invisible nicotine vapor is absorbed in the oral mucosa and gets into the bloodstream. Each of those cartridges that you see here lasts for about 3 20-minute puffing sessions. You can use up to 16 cartridges per day, and the most common side effects are throat irritation and cough. The last nicotine replacement, short-acting nicotine replacement, is nicotine nasal spray, also by prescription. This is nasal mucosal absorption of nicotine. It gives a little higher dose and works a little quicker than other short-acting forms of nicotine replacement. So if you're thinking about patients who have significant cravings and withdrawal symptoms, maybe first thing in the morning, early morning cravings, you may want to consider the nicotine nasal spray. The main thing with the nasal spray in terms of its use is you don't want to sniff it like you would other nose sprays like nasal steroids. You basically tilt your head back, you insert the nasal spray, you spray it, it's absorbed in the lining of the nasal mucosa and gets into the bloodstream. A dose is 1 spray in each nostril, and you can use up to 40 doses per day. Most common side effect with the nasal spray is some nasal irritation or sneezing. So in wrapping up with Charles, you decided to use a short-acting NRT, which is active and can be used as needed for withdrawal symptoms, as Susan had mentioned, combined with a passive medication like the patch, which provides continuous nicotine throughout the day. In terms of choosing how to choose which short-acting medication, a lot of that has to do with patient preference. Sometimes patients will have certain success with certain medications or things that they want to avoid. There may be some comorbid precautions. For example, someone with a lot of dental work, or TMJ may want to avoid the gum. Someone with sinus issues may want to avoid the nasal spray. And then access to the medications. Again, keeping in mind for the short-acting, gum and lozenge are over-the-counter. Inhaler and nasal spray require a prescription. With a lot of insurance companies throughout the country, even the over-the-counter medications may be covered by insurance if the person has a prescription for that medication. So keep that in mind. There are many insurances that if you write a prescription for nicotine gum or lozenges, it will be covered. So for Charles, again, a conversation as you sit down with him, you decide to use the 21 milligram patch and 4 milligram lozenge as needed starting on his quit date. So you kind of follow up with Charles, as Susan had mentioned. The last A was following up, so you was arranging follow-up. So you follow up with Charles a few days later. His friend offered him a cigarette. This is a very common scenario. He was wearing the patch. He smoked that cigarette, was worried he was going to have a heart attack, so he took the patch off and smoked the rest of that pack. Very common thing that we come across. So things to emphasize to Charles is that if you do smoke while using the patch or NRT, it is not a dangerous situation. So we certainly don't encourage people to smoke continuously while they're wearing nicotine patches, but it's important for people to understand the actual risk. So if you smoke while wearing the patch, you don't want to stop the medication. You actually want to keep the patch on and just not smoke any more cigarettes. So people need an overall plan on dealing with slips and lapses because they are going to happen as part of the natural history of tobacco use. So in fact, the labeling for over-the-counter nicotine replacement was changed a few years ago by the FDA, and it now includes explicit language that says that there are no safety concerns in combining multiple forms of NRT. There are no significant safety concerns if you happen to smoke while using NRT, and that you should just continue the medication if that happens. And in terms of duration, that use of NRT longer than the 8 to 12 week period is perfectly safe. So in following up with Charles in terms of questions, you just want to, again, re-emphasize the lapses and slips and how to deal with them and how to use the medication in a proper way. Okay. Our second patient is Rachel. So Rachel is a 21-year-old woman. She smokes 11 cigarettes per day, and her first cigarette is 3 or more hours after waking. She's tried quitting once before, but has never used any medication. She's concerned about weight gain when she quits, has a BMI of 30, and has a history of depression in the past, but not currently. Otherwise, she's otherwise healthy. So which medication to recommend with Rachel? Again, you're considering her level of dependence, which she has a heaviness of smoking index of 1, which is rather low. She does have a history of depression. She has obesity and is concerned about weight gain when she quits. She's never really used any medication before. So in terms of weight gain, again, a very common concern with people when making a quit attempt. And you can see that not everyone who quits smoking gains weight. A significant proportion of people do gain weight, but the amount of weight that people typically will gain after quitting smoking tends to be on the smaller side, so somewhere in the range of 2 to 4 kilograms. There are some people who are more concerned about weight gain and tend to gain weight more than others. And certainly the concern about weight gain can be a deterrent and a risk factor for relapse. So in terms of medications, bupropion, nicotine replacement, and varenicline all limit post-cessation weight gain while you're taking the medication. And you can see bupropion tends to have the largest impact on reducing weight gain, followed by nicotine replacement. When you follow people out beyond when they stop taking the medication, you follow them out to a year, there is an effect that the weight does tend to come back. So the predominant effect occurs while taking the medication. In terms of Rachel's depression, so depressed mood is a withdrawal symptom, as Susan had mentioned. It's more common in people with a history of depression and is a risk factor for relapse. So it's very important to monitor mood when you're treating people for their tobacco use, regardless of any medication that you're going to use or if you're not using any medications. There is evidence that bupropion increases cessation rates in smokers with a history of depression, doubling those rates. So again, in a conversation, a collaborative discussion with Rachel, you decide that bupropion may be the best choice for her together, and she has a lower level of dependence. She's concerned about weight gain, and bupropion can blunt that. And she has a history of depression, which makes bupropion a good choice. So again, in terms of prescribing bupropion, this is a medication, as Dr. Urban mentioned, has been around for a long time now as an antidepressant, and more recently, although still for a couple of decades, as a tobacco treatment medication. She had mentioned the seizure risk, which is the main contraindication. We usually start bupropion at 150 milligrams once a day for between 3 to 7 days, and then increase the dose to 150 milligrams twice a day. Now, bupropion comes in a couple formulations. One is the SR, which is a twice-a-day formulation. The other is an XL, which is a once-a-day formulation. So the standard treatment, again, would be 150 milligrams and then increasing to 300 milligrams. You want to start this medication for about a week before the quit date. So as opposed to nicotine replacement, where the standard treatment is starting it on the quit date, bupropion is started about a week before, and the duration is similar, about up to 12 weeks. There is evidence that continuing bupropion for longer than that can be perfectly safe. The most common side effect with bupropion is insomnia. If you're taking it twice a day, you try to not take the second dose too close to bedtime. Okay, so in terms of following up with Rachel, her main concerns were weight gain and depressed mood. So you want to continue to monitor her for these things. If her mood does take a turn for the worst, you want to be prepared to refer her for additional treatment or support as needed. Okay, our final case is Richard. So Richard is a 48-year-old man. He smokes 2 packs per day. He has his first cigarette 20 minutes after waking. He's tried quitting many times in the past, but has always relapsed. He had tried NRT in the past and says it does not work. He has a history of schizophrenia on medication. He also has hypertension, diabetes, hyperlipidemia, and coronary artery disease with an MI 5 years ago. He's on various medications for these conditions. So the first thing I'm going to point out is we had mentioned efficacy. Medication efficacy is the first thing you want to consider. And a lot of times people have heard that folks who use tobacco who have serious mental health diagnoses, such as schizophrenia, just can't quit smoking. And a lot of times people give up on patients with serious mental illness. This is results in terms of efficacy of various medications from the EAGLES trial. The EAGLES trial is the largest multi-center randomized clinical trial for tobacco treatment in the world. And it enrolled over 8,000 smokers and used various medications, including varenicline, bupropion, nicotine patch, and of course, placebo. And I'll draw your attention to the middle panel of bars. And what you see here is people enrolled in the EAGLES trial included people both with and without psychiatric comorbidity. And in the middle panel, you see people with psychiatric comorbidity, such as schizophrenia, having statistically beneficial effects of all of these tobacco treatment medications, varenicline, bupropion, nicotine replacement, all statistically beneficial in people with serious mental illness. So in terms of medication efficacy, people with schizophrenia can certainly successfully quit smoking. So again, you have a collaborative conversation with Richard about which medications he may want to use. We talked about the efficacy, that all of these medicines are efficacious in people. He has a fairly high level of nicotine dependence. He has psychiatric history with his diagnosis of schizophrenia. He also has coronary artery disease. He feels that NRT had not helped him in the past and is not really interested in using NRT again. So specifically, going back to the EAGLES trial, in terms of neuropsychiatric side effects, so you've probably heard that there were some issues around varenicline and neuropsychiatric effects. These are data looking specifically at those neuropsychiatric effects, both on the left side, people without a history of psychiatric diagnoses, and on the right panel, people with a history of psychiatric diagnoses. And what you see is that all of these medications, varenicline, bupropion, and nicotine replacement, all have no increased neuropsychiatric effects compared to placebo. So all of the medications, whether in people with existing psychiatric conditions or without, do not increase neuropsychiatric side effects. So based on that, if you recall, varenicline had a black box warning that the FDA had put on in 2009 for serious neuropsychiatric effects, including depressed mood and suicidal behavior. In 2016, largely based on the results from the Eagles trial, the FDA has removed the black box warning and does still recommend that we continuously monitor people for these symptoms, but the black box warning is no longer present on varenicline. What about Richard's heart disease? So he has stable coronary disease. He had an MI 5 years ago. Can he take varenicline? So there are a couple well-designed studies that have been reported, and basically the conclusions are that varenicline, as well as nicotine replacement and bupropion, are safe medications to use in smokers with stable coronary artery disease. So you and Richard decide that varenicline is the medication he wants to use. In terms of the use, we usually start with varenicline and taper it up with increasing doses over the first week. So 0.5 milligram daily for 3 days, and then 0.5 milligrams twice a day for 4 days, finally starting on the second week with the 1 milligram twice a day dose. In terms of the quit date, the standard quit date with varenicline is day 8 when you've started that 1 milligram twice a day dose. However, we're going to talk later that there can be some flexibility in terms of the dosing and the quit date for varenicline. It's also, there's a reduced to quit indication for varenicline. So again, people who are unable to initially quit completely may want to use varenicline. We'll talk about that a little later. Varenicline is excreted through the kidneys, so people who have significant renal impairment should either use a lower dose or choose a different medication. Again, the standard duration is 12 weeks, about 3 months, but we'll talk about there is evidence that continuing it for an additional 3 months may be beneficial. The most common side effect with varenicline is nausea. So we usually, again, recommend that people take varenicline with food and a full glass of water. There's also some report of some insomnia and abnormal dreams in the use of varenicline. So again, following up with Richard, in terms of side effects, someone with a history of schizophrenia who you're going to decide to use varenicline on, you want to discuss the potential for mood-related and neuropsychiatric adverse events. You'll probably discuss the Eagles results. But I generally find as an internist, to be honest with you, if I'm treating someone with a history of schizophrenia or other serious mental illness like bipolar disorder, I'll probably want to have some type of consultation with their psychiatrist just to make sure that we're all on the same page in terms of using his medications. Okay, so those are our 3 cases that kind of illustrate the use of these medications. And I'm now going to turn things back over to Susan so we can discuss how we might increase quit rates with certain techniques such as preloading, extending duration, and the use of combination therapy.
Okay. Thank you. So we've heard a little bit about Charles, Rachel, and Richard. Charles took combination patch plus lozenge, Rachel bupropion, Richard varenicline. Quit rates with optimal treatment are less than 40% at 6 months. Is there some way that we can increase the effectiveness of the medications that we have? For example, can we start them earlier? Can we give them longer? Can we combine one medication with another? So giving them earlier while the patient is still smoking is called preloading, pre-cessation, or pre-quit. And of course, giving them longer is called extended duration. So there is very good evidence and a lot of evidence that preloading and extended duration with varenicline significantly increases quit rates. For example, in 2011, Hayek and al. Looked at a 4-week pre-quit varenicline group versus a standard varenicline group where they started the varenicline 1 week prior to the quit date. Both groups were treated with varenicline for 12 weeks. And Hayek and al. Found increased abstinence at the end of treatment, 12 weeks in the pre-quit group. You can see more than double abstinence. Similarly, several studies on extended duration, giving it longer than the standard 3 months. Tonstad and al. Published a study in 2006, treating all smokers with varenicline for 12 weeks, and then taking those smokers who were abstinent at the end of the 12 weeks and randomizing them to an additional 12 weeks or placebo. And Tonstad and al. Found increased abstinence at the end of treatment, the end of 24 weeks for the extended duration group. And this increased abstinence persisted up to 52 weeks. Evans looked at a group very difficult to treat, as we know, schizophrenics and bipolar patients, published the study in 2014. Again, treated all smokers for 12 weeks with varenicline and took those who were abstinent at the end of the 12-week treatment and randomized those to 40 more weeks of varenicline or placebo. And Evans and al. Found increased abstinence at the end of the 52 weeks for the extended duration group. That increased abstinence persisted at 64 weeks and at 76 weeks. So on the basis of these and other studies, in 2011, the FDA approved a flexible quit date for varenicline, where the smoker can quit any time between day 8 and 35 after starting varenicline. And they also approved a longer duration of treatment, 6 months, as opposed to the usual 3 months. So what about preloading, NRT preloading? NRT preloading can also lead to higher quit rates. Study published in 2018 by Aveyard and others looked at a 4-week preloading interval for the patch versus patch started on the quit date, and found increased abstinence at 6 months. And that increased abstinence persisted at 12 months, was still significantly different. However, in 2019, in a Cochrane review, relative risk of abstinence was 1.25 for preloading patch gum or patch plus gum, favoring preloading. However, when they removed 5 studies thought to be at high risk of bias, it was not statistically significant. What about extended duration of NRT? Several studies have found some benefit of extended duration, longer duration of NRT whilst on treatment, up to 24 weeks. So for example, in 2010, Schnall and others looked at standard 8-week treatment versus the extended 24-week treatment with NRT. And they found increased abstinence, end of treatment, 24 weeks for the extended group. However, this was no longer statistically significant at 52 weeks. In 2015, Schnall and others published another study looking at 8 weeks, 24 weeks, and 52 weeks of NRT. At 24 weeks, they found increased abstinence for the extended groups. However, at 52 weeks, at the end of treatment for the 52-week extended group, there was no significantly increased abstinence for the extended group. However, it was noticed there was very decreased compliance in that extended group. So it's not clear what the reason is for that problem, but it could have been decreased compliance. And in a Cochrane review published 2019, insufficient evidence for extended duration. But it is certainly safe to use, and there's no major increase in adverse effects. There are only a few studies for bupropion, not a lot of evidence. One small study on preloading and bupropion, looking at pre-quit bupropion 4 weeks versus the standard treatment 1 week prior to the quit date. And looking at those two groups at the end of 4 weeks only, they found increased abstinence at that time, at 4 weeks, for the pre-quit group. Small study and not long follow-up. Another study published in 2001, Extended Bupropion, Hayes and others, looked at those smokers who were treated for 7 weeks with bupropion and randomized those who had quit to bupropion versus placebo for another 45 weeks. And they found at the end of 52 weeks, end of treatment for the extended group, increased abstinence. That carried out to 78 weeks, still increased abstinence at 78 weeks for the extended treated group. However, no statistically significant difference at 104 weeks. So let's look now for a minute or two at combination therapies. As we said, combination NRT is more effective than single NRT. So patch plus short acting is more effective than a single form of NRT. And in the Cochrane review published in 2018, risk ratio of abstinence was 1.25, favoring combination NRT, patch plus short acting. In addition, combination bupropion with NRT is FDA approved and has been found to be more effective than bupropion alone. So combination bupropion plus NRT is more effective than bupropion alone. Risk ratio 1.24 in one of the Cochrane reviews. However, looking at the Cochrane review from 2014, combination bupropion and NRT versus NRT alone did show mixed results. So let's turn to combinations not yet FDA approved. Let's look at varenicline and the patch. A couple of studies done had negative results for various reasons. Hayek in 2013, probably not powered sufficiently to get results. Raymond in 2014. But I want to point out and talk about Kogellenberg's study published in 2014. Combination varenicline and patch versus varenicline alone. They found that the combination varenicline and patch group had higher abstinence at 12 weeks and at 24 weeks. Significantly increased abstinence. However, I want to point out one thing about this study, which is they used the patch, they started the nicotine patch in the combination group 2 weeks prior to the quit date. This sounds like preloading, right? So it's difficult to know what effect the preloading had versus what effect the combination had, and so on. You're looking at both things together. One thing is clear is that these two medications, the combination of varenicline and nicotine patch together, were well tolerated. A few perhaps more side effects here and there, but overall well tolerated. So let's look for a minute at varenicline and bupropion now. So in 2014, Ebert and others published a study looking at the combination varenicline and bupropion versus varenicline alone. They found increased abstinence, prolonged abstinence at 12 weeks and 26 weeks. However, when they looked at week 52, there was still a suggestion of increased abstinence for the combination group, but it was not statistically significant. There were, again, this combination was well tolerated. A few extra symptoms of anxiety and depressive symptoms in the combination group. So In 2019, Zong and others published a meta-analysis looking at combination varenicline and bupropion. You can see on the left side of the slide 4 of the studies that had been done. And they calculated the risk ratio of abstinence over all 4 studies, and you can see that it's 1.15 in favor of combination therapy. Not very impressive, but significant, 1.15. When they then reanalyzed the data for just the highly dependent smokers, they found a risk ratio of abstinence of 1.63 favoring combination therapy. So it seems that the combination therapy, and it makes sense, that combination therapy is going to be more effective in the more highly dependent smokers. So let's go back to our 3 smokers, Charles, Rachel, and Richard. Could we have increased the effectiveness of the medications they were on? So Charles was put on combination patch plus lozenge as needed. He could start the patch 2 to 4 weeks prior to the quit date, preloading. And he could take it longer than the 3 months. And there is certainly no harm at all in extending duration of treatment for the patch past 3 months. And potentially there is benefit. Rachel was put on bupropion. We could add NRT to the bupropion. We know that the combination NRT and bupropion is more effective than bupropion alone. And we could continue that combination treatment longer than 3 months. We could continue it 6 months. And it is safe to do so. Richard, who was started varenicline 1 week prior to the quit date, which is the standard treatment, could actually start varenicline 35 days prior to the quit date. Again, preloading. We know it's more effective than standard treatment. And he could take varenicline for 6 months rather than 3 months. And we have evidence that that is more effective as well. So let's summarize some of what we've talked about. Many smokers will have a chronic disease of nicotine dependence. And those are the smokers we've been talking about in this webinar. These smokers have more difficulty quitting, and medications will be more effective in these smokers. They will need medications and counseling. Comprehensive treatment includes both. Both together are more effective than one or the other alone. We talked about evaluating smokers for cessation, medication. What goes into that? Having a dialogue with the smoker. What do they prefer? What are their comorbidities? What's their nicotine dependence? And what are the characteristics of the medication? We said that nicotine replacement therapy, remember there are 5 forms, bupropion and varenicline, are all effective in helping smokers quit. We also said varenicline is more effective than NRT, a single form of NRT, and it's more effective than bupropion. And it's similarly effective as combination NRT patch plus short-acting form. It's important to remember that varenicline, as well as NRT and bupropion, is safe in people with psychiatric disease. We talked about the Eagles trial. And I think as of February 2020, varenicline or combination NRT patch plus short-acting form may be best first-line treatments. Then we talked about some newer information, newer developments. How can we increase the effectiveness of medication with preloading, extended duration, and combination? We said that 2 combinations are currently FDA approved. We talked about the NRT patch plus short-acting form is FDA approved and more effective than single NRT. And combination bupropion with NRT is also FDA approved and more effective than bupropion alone. Two combinations not yet FDA approved as of February 2020 have potential for being effective and are generally safe. Combination varenicline with NRT and combination varenicline with bupropion. Preloading extended duration can be useful, can increase benefit. For example, varenicline can be more effective with preloading. We talked about the flexible quit date, quitting 8 to 35 days after starting varenicline. So varenicline can be more effective with preloading. It can also be more effective with longer duration, 6-month duration as opposed to 3-month duration. There is some suggestion that NRT may be more effective with preloading, and we know it is tolerated and safe with preloading. And NRT and bupropion both can be given longer than 3 months. That is well tolerated and safe as well. So we've been talking about medications for cessation in smokers, nicotine-dependent adult smokers who want to quit in the next 2 to 4 weeks. We've mentioned the 5 A's model. Ask if they use tobacco, specifically cigarettes in this case, but any tobacco product. Advise to quit. Assess if they're ready to quit in the next 2 to 4 weeks. If they are ready to quit, assist them with quitting with medication and counseling. And then arranging follow-up and support is critical as well. This is the model that has been generally used now for decades. There's another model, the opt-out model, which has some advantages. In this model, you offer treatment to all smokers, including those not ready to quit. So you would then increase the reach by including more smokers for treatment. And it is established, there is good evidence that varenicline and NRT can be effective in abstinence for these smokers. Finally, it's important to focus our efforts particularly on groups with higher prevalence, psychiatric patients, substance abusers, and also to focus efforts on smokers who are being screened for lung cancer with low-dose CT, as well as those undergoing surgery or being hospitalized. So with that, I'd like to thank everyone for participating in our webinar, and we'd be delighted to take any questions.
Thank you, Dr. Urban.
Back to our organizer.
Thank you, Dr. Urban and Dr. Steinberg. I will now open the dialog box up for questions. We have received a couple. Can you briefly talk about current guidelines for lung cancer screening in smokers?
So I can start with that. So the guidelines. So lung cancer screening is it's a grade B recommendation from the U.S. Preventive Services Task Force. The current guidelines, there's a couple guidelines out there, but the U.S. Preventive Services Task Force recommends that people age 55 to 80 who are either current smokers or who have quit in the past 15 years and who have a 30-pack year history or greater would be eligible for lung cancer screening. And I just to talk a little about lung cancer screening, the evidence for lung cancer screening is actually pretty substantial. The National Lung Screening Trial showed that there was a 20% decrease in lung cancer mortality in people who got annual low-dose CT scans versus chest X-ray, and about a 7% decrease in mortality overall from all causes. So the evidence is actually pretty strong for lung cancer screening compared to some of the other cancer screenings that we have commonly adopted. There's clearly a link. The people who are getting lung cancer screening are also, a lot of them are current smokers. So being able to link tobacco treatment to lung cancer screening programs has been shown to be very effective and is a good opportunity for people who do one or the other.
Thank you. Thank you, Dr. Steinberg. The next question, is there any new cessation medications in trials right now?
So again, I can take the first crack, and Susan can chime in. I'm not aware that there is anything that's in any advanced clinical trials right now. Every so often, you see some medications that have other indications are being tested for tobacco treatment. Some of them pan out, as we've seen with things like bupropion, and some do not pan out. There is a medication that's used outside the United States called cytosine, which was published in the New England Journal of Medicine a few years back. So cytosine is an effective medication for tobacco treatment. Again, not approved here in the United States by the FDA, but is used in other countries. At some point in the future, if it becomes approved here in the FDA, it's a medication. It's kind of a poor man's varenicline. The downside is you have to take it up to 6 times a day, but it is effective and has few side effects.
Okay, and one last question, comment. Effective evidence-based strategy for a hospitalist to implement?
I'll start, and Susan can finish after me. So we run a hospitalist program here at Rutgers, and I work with our hospitalist team in terms of delivering effective tobacco treatment. There's good evidence that intervening during hospitalization, getting people to use cessation pharmacotherapy like nicotine replacement during hospitalization leads to increased use of those medications after discharge. The period immediately following discharge is obviously a high risk for relapse time period. People who have abstained by forced abstinence during hospitalization now leaving the hospital. So there is evidence that people who use tobacco treatment medications during hospitalization are more likely to continue using them after discharge. And in tobacco treatment interventions that begin during hospitalization, if they include a 1-month follow-up period, they're much more effective in the long term.
Great. Thank you. Well, that concludes our questions for today. This information has been very essential. Thank you, Dr. Urban and Dr. Steinberg. I'd like to remind our participants that I will be sending an email to all of you this afternoon in regards to the CME certificate and the MOC. We will have the recorded version of the webinar on our website at nyacp.org, and you'll all be getting a copy of the handouts in a PDF form. This concludes our webinar for today. Yes, Dr. Urban.
I just want to add one last comment, which is we'll also be sending out a list of resources for people.
Great.
Including New York State quit lines, websites, benefits, smoking cessation benefits in Medicaid, Medicare coverage, some few slides on lung cancer screening, and some key points. So there'll be some resources sent out along with the regular slides.
Perfect. They'll be included with the handouts that we send out later on today. Thank you, Dr. Urban. That's excellent. Alrighty, so this will conclude our webinar, everybody. Thank you and have a great day. Bye.